I'd like to welcome everybody to this first webinar for 2023 for the Key Populations Community of Practice. And we have a very important issue that we're going to consider today about data and measurement and monitoring of our programs with and for key populations. I think there are two main principles we really have to keep in mind throughout all our work with key populations. Firstly, we have to be human rights based, but we also have to be evidence informed. And to do that, we have to collect good data. And often there are some significant data gaps in our monitoring and our surveillance and surveys of key population programming and organizations, so that the amount of data that we have is often missing or incomplete, and which makes it difficult for us to really direct the most appropriate programming and make sure that it's tailored and effective and is making a difference to the key populations who we're trying to work with. So we've got a very tight program tonight or today. And first of all, I'd like to remind you that most of the presentations are in English, but that we will have a Russian speaker. And down at the bottom, you will see in the menu interpretation. There you can choose the language of your choice. And we have interpreters online who will be providing interpretation throughout. So please make sure to select your appropriate language. The first series of speakers, we've got three speakers who are going to set the scene globally and talk about some of the global AIDS strategy global targets as they relate to key populations. We're going to hear about some of the investment we need to make into ensuring robust monitoring and evaluation of key populations programs, and also gathering data from different sources so that we triangulate and validate the data that we collect to try and get the most accurate information. So I'd like to first of all, ask Keith Sabin, who's an epidemiologist with UNAIDS Secretariat, and I'd like to invite Keith to make some opening remarks. Thank you very much, Keith.
Next slide, please.
I think we can go on to the next one. Here we are, Keith,
Sorry, I lost my connection there for a second. All right, so I just want to talk about where we stand with what we know and what we are collecting thus far. So, and just to reiterate something that I think many on this call will know is that if we really want to end AIDS as a public health problem by 2030, it won't happen unless we prioritize key populations in a global fashion. Next slide, please. As we talk about all of this, we need to contextualize it by saying there is a public health approach, and the targets that we have for that can we achieve our targets without certain groups? And this is a very utilitarian approach. However, we take a rights-based approach where we want to apply our interventions and all of our work to all possible groups. And so this is an equity approach, and that is at the center of what we are trying to do. Next slide, please. So as many of you have probably seen, we produce this report every year, and we are currently not on a trajectory that will bring us to our target to reduce new HIV infections by 2025 to 200,000. And we're going to miss that target unless we severely create an inflection point downward. And right now, we don't have evidence that that is going to happen. Next slide, please. Similarly, looking at deaths, which is largely impacted by ART expansion, we're much closer to that target, but we're still not on a trajectory to hit it. Next slide, please. And one of the reasons for this, for missing this target, is that many new infections seem to be occurring among key populations and their various sex partners, whether they be clients of sex workers, and then of course, the spouses and non-sex work partners of those clients, and then other sex partners of the various key population communities. Next slide, please. So the Sustainable Development Goal states very clearly that the number of new infections per 1,000 uninfected population includes disaggregation by different key population communities. And so it's incumbent upon us to have the data and the information we need to make those disaggregations so that we can better plan our epidemic responses, both nationally and subnationally. Next slide, please. So this is just the same distribution as the donut that I showed earlier, but broken out by sub-Saharan Africa, which has, for most countries in sub-Saharan Africa, which is the middle pie, they have an appreciably different distribution of new infections as compared to the rest of the world, where the epidemics are largely centered among key populations. But as you can see in the center pie, we are right around 50% based on our current estimate. For 50% are occurring among key populations and their sex partners, 50% are occurring among the rest of the communities. And that's the result of, largely the result of ART reaching certain segments of the population and perhaps not certain segments of the rest of the population. Next slide, please. So as we've seen for a number of years now, the relative risk of acquisition of HIV among different key populations is exceedingly high. Keep in mind that a relative risk of 1.5 or 2 is generally considered very high. So we're looking at 14 to 35 among these key population subpopulations. And what we're seeing as we look at trends, and this slide is a little bit outdated because we haven't done it. Next slide, this one, thanks. It's a little outdated because we haven't been able to update it, but we will try. We're trying to do that for this year. But I think the trends will remain largely the same, and that is we've seen no progress among female sex workers, people who inject drugs, and transgender people, while we've seen a very appreciable worsening of the epidemic among gay men and other men who have sex with men. So if we don't address this, the chances of meeting our larger targets are very slim. Next slide, please. Part of the challenge in meeting these targets is that many countries are still underestimating or simply not counting the number of members in each key population. So here we see a slide depicting the number of uncounted members of each of the populations, which is where there are counts at all, that's reflected in orange, and where there are no data whatsoever is reflected in the greenish yellow color, at least on my slide, that's the color. So without these people being counted in the countries, it's very difficult to plan a response. Next slide, please. Nonetheless, UNAIDS and the global community have come out with these targets for 2025. And we've segmented the populations into those who are at very high risk of HIV acquisition, those who are at quote unquote, simply high risk, and then those who are at moderate and low risk. And so by creating these thresholds, we feel that we can better target our activities towards those who are very high risk and perhaps be more efficient by not spending as much effort on those who are at lower risk. Next slide, please. And here are just some targets, most of which, for prevention activities, most of which are in the 95% range. And that applies to, especially to those who are at very high risk based on the previous slide. And then also we have somewhat lower targets for those who, for distribution of PrEP. And next slide, please. Now, just to give a sense of some of the distribution of high risk and medium high risk, these are some of the estimates we came up with for just a random sample, well, the G's and the H's in our spreadsheet of who is at high risk within the estimated size of a particular population. So in the case of Ghana, we're talking about roughly 82,000 people who are considered to be at high risk, which is 61% of their size estimate. Now, I'm not going to go into the methods of this, but it's something that we worked on together with Avenir Health, and these are the basis for some of the targets that we've developed thus far. Next slide, please. Now, if we translate those coverage targets to actual numbers, this is what we're talking about. We need to reach approximately 1 million female sex workers who are considered to be at very high risk. We need to reach 4 million men who have sex with men at very high risk. Now, some of these numbers would be larger if we're considering but also the high risk and the moderate risk, which is something we absolutely need to do. But if we were to focus on the highest risk, we're still looking at very large numbers. Next slide, please. The number of people who receive PrEP is, outside of a handful of countries, still very low. So we're falling very short of our PrEP targets at this point in time. Next slide, please. And here is just a different way of accounting for that. The targets are reflected with the red dots, and the blue bars are where we sit and in terms of falling short. Only East and Southern Africa and Western Central Africa are remotely close. MENA, we could say that's close, but there's very little activity in MENA in terms of PrEP at this point. Next slide, please. This is another way of depicting our coverage targets. And just to say that if the triangle in black reaches the edge of the triangle in the different colors, that means that they've achieved their target. So if we look at the lower left-hand circle, we can see that the target for reaching sterile injecting equipment at the last injection is very close to the target, because the black shape reaches the edge of the orange shape. But of course, only 3 countries are informing that. So this is just to say that if you look at these figures, the black lines are falling very far short of the colored lines, and that indicates a gap in our prevention coverage. Next slide, please.
Good morning, good afternoon, everyone. Thank you to the organizers.
Well, that was my last slide, so I think we're turning it over to Kate Namrita's video.
Right, thank you very much, Keith, for that.
Good afternoon, everyone. Thank you to the organizers.
Sorry, I was just going to thank you, Keith, for that scene setting and show the power of data. Even though we can see that we're way off some of those targets, it really enables us to focus and see where we need to expand and scale up our programs. So now we have 2 recordings from Kate and Amrita who are both with Johns Hopkins University. So we can start the recording. Thank you.
Good morning, good afternoon, everyone. Thank you to the organizers for the opportunity to present today. My name is Amrita Rao, and I'm faculty at the Johns Hopkins School of Public Health. Together with my colleague, Dr. Kate Ruchinsky, who is also faculty at the school, we will present on the utility of repurposing program data and opportunities to answer program-relevant questions using routinely collected data. In today's presentation, we will briefly walk through what routinely collected data are, how they might be used, and challenges and opportunities to using these data. We will spend the majority of the presentation sharing a series of 3 case studies that represent some of our recent work in applying these concepts. So, routinely collected data. As likely a refresher for most in attendance, routinely collected data are data collected for purposes other than research or without specific research questions developed prior to collection. These data are collected to support clinical management of patients and/or for monitoring and evaluation of program activities, or for general surveillance. Often when people think of routinely collected data, they think of clinical information from health records, but routinely collected data can also include health administrative data and program registers. The process of data collection and capture varies depending on the specific program, the clinical encounter, and a number of other factors. This is just showing an example of the data collection and capture for a PrEP clinical encounter. So because the primary purpose of this data collection is for clinical management, that is the primary priority, and there are potentially multiple opportunities for this process to go awry. So first, the duration or quality of clinical encounters may vary with changing case burden over time or changing staff with different levels of training. The clinical environment may be fast-paced, and certain fields in a data collection tool may seem redundant or not useful for clinical management and therefore may get left blank. Physical folders may be removed for use, which may challenge linking of forms for the same individual over time. And there's always the possibility of data entry and linkage error during data capture.
So the use of program data for answering questions of impact comes with both challenges and opportunities. Challenges are that data are regularly incomplete or messy. It may be difficult to access individual level data, and it might also be difficult to link individuals over time, particularly as they're switching to different clinics or if they've migrated out of the area. And then there are also competing priorities to data collection, often by staff. But there are also tremendous opportunities. These are data from a real-world setting, and perhaps findings may be more generalizable than research conducted through dedicated studies. Data are already being collected, so there are no additional resources or person power that are needed to collect data. There's an opportunity to study much larger groups of individuals and then also ask questions that would otherwise be unethical or too expensive to study. So I think the key to the development of really meaningful questions of impact is both science and art, with the art being the development of a key partnership where we can work with partners to actually develop research capacity in-house. So questions developed can and should be responsive to programmatic needs and gaps in knowledge, including demand for services, available resources, implementation, and identification of hotspots, and continuous feedback and adaptation of approaches to those implementing the actual program is quite critical. So I think in sum, there is tremendous opportunity for impact in working with programmatic data. In utilizing these data in this specific way, researchers and programmers are not only able to shed light on program relevant questions, but really have this added ability to examine and ultimately strengthen program systems along the way. And this includes how data are captured, how data are managed, and then ultimately used.
So switching gears, we're now going to share 3 different case studies where we made use of routinely collected data to answer program relevant research questions. In the first example, we examined patterns of PrEP initiation, discontinuation, reinitiation, and cycling among female sex workers and adolescent girls and young women who initiated PrEP in South Africa. This and the next case study example are made possible by a long-standing research practice partnership between TB HIV Care and Johns Hopkins University. TB HIV Care is a South African NGO that serves as the largest PrEP provider to young women in South Africa. They operate at multiple sites across 6 provinces. Sites offer services through mobile vans and drop-in center clinics. To date, the program has initiated more than 40,000 young women at high risk on PrEP. Available program data were reviewed together, and questions were developed to be responsive to program needs and gaps in knowledge. Our analyses here included FSW and AGYW receiving prevention services through TB HIV Care. The data were inclusive of multiple sites across the 6 provinces from 2016 through 2021 for FSW and from 2018 to 2020 for AGYW. We plotted the monthly proportion of eligible HIV-negative encounters who initiated PrEP over calendar time. We estimated time to PrEP discontinuation and plotted something called Kaplan-Meier survival curves. We estimated time to reinitiation and used an approach called group-based trajectory modeling to look at cycling. So here are just some of the different figures we were able to put together for initiation, discontinuation, and cycling. And for the sake of time, we won't get into too many details about this, but we found that the number and proportion of initiations increased each year for both FSW and AGYW. 1 month persistence was about 40% for both populations. By 7 months, less than 10% remained on PrEP. The majority of FSW and AGYW experienced what we call limited use of PrEP, but some form of cycling was not uncommon. And if you're interested in reading more about this particular study, we can share the link to the paper that was recently published in AIDS. So next, we wanted to evaluate the impact of implementation strategies on PrEP persistence among FSW and AGYW served by TB HIV Care. The primary outcome of this analysis was PrEP persistence at 1 month, defined as whether or not a client returned to pick up her PrEP refill at 1 month following initiation. Data at the individual level were aggregated to produce monthly site-specific counts of the number of women who picked up their 1 month PrEP refills and counts of the number of women who initiated PrEP in the prior month. TB HIV Care introduced several implementation strategies to try to promote PrEP persistence, and they're listed here. They included strategies that targeted community level, clinic level, and individual level barriers. So we evaluated the independent impact of clinical mentoring for providers, SMS refill reminders and support texts, the case management approach, and the loyalty rewards program among FSW. The FSW statistical model we used is represented by the following equation. And this figure shows the monthly trends in 1 month PrEP persistence by site for FSW visualized against the introduction of several implementation strategies. Each strategy is represented by a dashed line, purple for loyalty rewards, blue for SMS, red for clinical mentoring, and green for case management. Not all of the strategies were implemented at all of the sites. For example, notice that there are only red lines for OR Tambo and Mngangundlovu. The loyalty rewards program was de-implemented for a short period, and this pause is represented by the shaded purple region. Data from 9 different FSW sites were included for a total of 299 site months and 11,020 total initiations. Clinical mentoring for providers was associated with a 12% relative increase in 1 month PrEP persistence, and SMS support texts and refill reminders were associated with a 33% relative increase, after adjusting for the impact of the other strategies and monthly COVID-19 cases. The analysis suggested no effect of the case management approach, and the loyalty rewards program was negatively associated with persistence. The paper that presents this work is currently under peer review. And with that, I'll now turn it over to Kate to present the last case study.
Thanks so much, Amrita. And we're going to talk a bit about how we leveraged program data to inform the extrapolation of population size estimates for FSW and MSM in Namibia. So we know that a lack of reliable population size estimates for key populations contributes to gaps in knowledge across the HIV cascade. Size estimates are often volatile and unreliable. They are frequently unavailable for rural or remote areas or settings where there are the most unmet needs. Small area estimation and extrapolation approaches can help fill in some of these gaps using other data sources or auxiliary data, but often program data are not considered when conducting small area estimation exercises. So in partnership with USAID through the DataFi Consortium, we were tasked with generating extrapolated population size estimates for key populations in Namibia. We were given a list of existing population size estimates for each population that was collected and generated across multiple years using multiple methods. And I think the intention of this table is not to really focus on the specific estimates themselves, but just to note that across the different regions, we have a lot of variation in the available size estimates based on the method that was used to generate those size estimates. So in addition to the population size estimates or direct estimates that were provided for each population, we were also provided additional auxiliary data as well as program data. And these program data generally captured quarterly indicators of engagement in programs such as the number of individuals that access services or the number of individuals that tested for HIV. While imperfect, you can almost think about these counts as a lower bound for the number of key populations in a given area or district. And I think one of the things that we've been thinking about as a group is how we can actually systematize the integration of program data in some of these small area estimation approaches. So we know folks at CDC have been working on this as well, and just wanted to highlight the work of Dr. Ian Fellows and colleagues here through the Triangulator, which we believe was previously called the Consensus Estimation Approach. So these are publicly available tools that exist online. We use this approach to actually combine our existing and disparate size estimates for each population across the different methods. In essence, the Triangulator leverages known information about the distribution of each population to inform a singular estimate. And then those estimates are actually weighted based on user-defined or perceived confidence in study quality. So for example, multiplier methods may be more rigorous than wisdom of the crowds methods. And here actually we were able to use the programmatic data as prior information to inform this entire process. So how did we actually do this? So this is an example of PSEs that were collected among sex workers in Zambia. Using multiple methods. So we ranked these existing population size estimation methods by levels of confidence and then conducted some internal tests where we varied the level of confidence. As I mentioned, we also used the programmatic data as priors to ground this work. And I would say that generally we saw similar results across the different permutations of confidence, aside from situations such as the test on the right, so test 3, where we used very high levels of confidence. So for example, here SSPSE is 99.9%. I'll just say that the existing size estimates range between about 80 and 5,500. And so you'll see here on the bottom, this process resulted in a weighted size estimate of around 430 for sex workers. And so these data actually show the generated size estimates before and after the inclusion of programmatic data. We use simple imputation, stratified imputation with HIV prevalence, and stratified imputation with population density as our imputation approaches here. We saw that the inclusion of programmatic data actually increased the proportion of FSW in regions where we had a higher HIV prevalence, so prevalence that was greater than the median, as well as in regions where we had a higher population density, so similar population density that was greater than the median. And then conversely, in those areas where we had a lower HIV prevalence or a lower population density, we saw the proportion of FSW decrease after the inclusion of programmatic data. And then interestingly for MSM, we saw a different pattern. So Irrespective of stratified imputation approach, we saw that there was a decrease in the total proportion of MSM after the inclusion of programmatic data. So this process generated size estimates for sex workers that varied across simple and stratified imputation. So here, national size estimates ranged from 4,777 to just over 13,000, comprising between 1.5% and 3.6% of all women between the ages of 15 and 49. And then for MSM, we saw national estimates that ranged from 4,611 to just over 10,000, comprising 0.7% and 1.5% of men between the ages of 15 and 49. So just to quickly summarize, using known small area estimation approaches, we combined epidemiologic and programmatic data to generate subnational and national size estimates for key populations in Namibia. The inclusion of programmatic data actually increased the proportion of predicted sex workers in high density and high prevalence regions and decreased the overall proportion of MSM in all regions. And future work is really needed to determine how best to include program data in some of these size estimation studies, ultimately bridging research with practice to support a more comprehensive HIV response. So we'll just close out with some thoughts on the larger presentation. So we hope we've made the case that programmatic data really represent a great opportunity for collaboration, for repurposing existing data and analyses, and infusing additional methodologic rigor. We just wanted to say thank you for inviting us to speak today. Please feel free to reach out to either myself or Dr. Rao with any questions. And we also wanted to offer thanks to our many partners that have supported this work over the course of many years. Thanks so much.
So I'd like to thank our three speakers who've set the scene. You can see the very exacting methods that are needed to get good size estimates for the populations we're working with. Obviously, this work is a partnership between the communities themselves, academic partners, and surveillance staff within the Ministries of Health and other experts who are brought in. So it's always a partnership that we need to maximize in order to get the best possible quality of data. We're going to do a quick Mentimeter now, and we have a question for you. I think the Mentimeter link will be put into the chat. Is that correct, Paranita? Yes, you'll see. If you look in the chat, there is a Mentimeter link. We'd like you to click on that and go there. And our question is, why would you prioritize monitoring and evaluation of key population programs in your country? So you can write one or two words or a quick phrase. Here we have the question. Why would you prioritize monitoring and evaluation of the key population programs in your country? So please click on the Mentimeter link and then you can type in your answer. We'll just spend a couple of minutes on this because we've got a very full agenda. But once we start getting some responses, we'll put those on the screen. Click on the link in the chat. Here we are, people starting to add. So we have a lack of data. We need to be evidence-based. We need to estimate the size of the populations and the coverage. What is our reach of our programs? And to do various investment analyses of the costs. And we can use the data for advocacy, for trying to influence the focus and the extent of programs and try to increase programs. We're getting a lot of very valid comments here about why we really need to have good quality data and need to spend time on this monitoring and evaluation, which often feels like it's taking us away from our direct program implementation, but it's really essential to know how effective are we, and are we reaching the people that we're trying to work with, and what is the impact, and are we getting towards our eventual goals. Yeah, I think we'll probably try to summarize these and present them. We can circulate them after the webinar. So I think we probably, without further ado, will go straight on. And here we're going to hear from another partner from our Ministries of Health who are involved in surveillance and monitoring. And first of all, we have two Ministry of Health officials from Nepal. Ministry of Health, we have Keshab Dubey and Niti Sedane, both from Nepal. And I would like to invite them to present on their experience of working on monitoring and evaluation of key populations. Keshab, will you go first?
Hi, good morning, good afternoon, everyone. This is Niti. I'll go first and it will be followed on by Dr. Keshab.
Okay, thank you.
Okay, so good afternoon, good morning once again. So we'll be sharing our experiences of KP monitoring through the use of DHIS2 platform that we are currently using. Like I said, I'll be doing the first part and then it will be followed on by Dr. Keshab. This is the basic outline of what we are going to present. We'll talk about the KP, special KP, what we mean by KP in Nepal, and then the background of our DHIS2 tracker individual best information system to strengthen the monitoring and evaluation of HIV program. There were certain issues until we had this one system of using DHIS2 system. So there were some issues that we wanted to solve. And then we'll talk about the features and benefits of the developed DHIS2 trackers information system to monitor and evaluate KP program, and we'll follow on with some conclusions. Next slide, please. So in Nepal, we consider like our key population in Nepal as described in our strategy are sex workers, both male and female, male having sex with men, transgender people, people who inject drugs, and there are migrant people and prison inmates. And we have KP service package that include prevention service, including like outreach education to condom lube distribution, to STI screening services, to some harm reduction package for these people who inject drugs. And for testing services include HIV testing and counseling services, HIV self-test, recency testing, index-based pattern testing, etc. And then there are treatment services for our KPs and other population as well, plus the viral load testing services. So once, as we are aware, this is the little background. Once any individual is infected with HIV, we are aware that he or she has to enroll in treatment for whole of entire life. And this recording of the treatment details and analyzing, reporting the outcomes using paper-based registers is very cumbersome. And until we had this DHIS2 system, the existing system was unable to track duplication of cases across the sites because there are 80 plus sites across the country. And if there's no unique identifier system, then there would be like issues of overestimation of ART coverage, double reporting of the same patient, clients to system, etc. Therefore, in addition, we also would not be able to answer what intervention or program were working and what was not, because we would not have this individual level information of PLHIV who are enrolled in HIV care. For an example, it was not possible to know the characteristics and reasons of poor performance of clients in HIV care in terms of adherence, retention, treatment failure, etc. And analyzing them was like not possible. Yeah, next slide, please. And in addition, as we are aware, these paper-based systems are time consuming, and it was difficult to report manually, and so submit aggregated monthly data to the system. And then it was difficult to generate real-time or at least latest data of clients on HIV care, like we would like to see on ART, how many cases are on ART, or how many cases are lost to follow-up or deaths, etc. It used to be very difficult. And the other problem was of like coordination and cooperation also, because it was lacking among the healthcare workers, especially in recording and reporting of HIV data, because there are vertical donors and this donor has their specific information systems requirement. So there was an overall lack of synergy in the efforts. Next slide, please. So these were the issues, and like the national program, it wanted to solve the issues and wanted a patient-centered concept that would prevent duplication of the patient records, that would provide easy access to individual level data at all levels, that would generate data for the entire HIV continuum, ensuring a unified source for recording and reporting HIV-related data to the national HMIS system, and also to facilitate monitoring outcomes and impact indicators, all program planning, and help health workers to offer custom care services to key population and PLHIV based on their specific needs at any given point of time. And the solution we thought for this was using of DHIS2 tracker, so that we could collect individual level data for whole HIV continuum. We also integrate DHIS2 with a biometric system and interconnecting an existing mobile health mHealth system also.
Sorry to interrupt, Nikki. Sorry, you're running a bit fast for the interpreters. If you could speak a little bit slower.
Okay, sorry. Okay, thanks.
Thank you.
So, okay, yeah, sure. So these were the things that the national government would like to solve. Therefore, as I said, the solution would be tracker, use of individual best tracker, and that would collect individual level data for whole HIV continuum, right from the prevention services to this viral load, etc. And then also it would integrate DHIS2 with a biometric system for client, for patient enrollment and verification. And then it could interconnect an existing mHealth system to use to generate SMS notification to PLHIV for improved retention in care. These were the solution that was discussed. Next, please.
A little bit slower.
Okay, I'll be slow. This is the, okay, I'll be slow. And then as I said, there was a lack of synergy. So with the leadership of government of Nepal, the national program that is called NCSC, and then there was financial and technical support from FHI 360, PEPFAR, Save the Children, Global Fund programs, and all the relevant stakeholders. We developed this information system, which underwent through a series of processes. And this slide shows about those processes, what we followed. For example, first we developed the forms because all the partners require different variables to report. Therefore, the variables were identified, and while identifying the variables, we considered national HIV strategic plan, because that would give us the major priorities. And then we do have to report on GAM, Global AIDS Monitoring report, that we have to prepare every year based on that. And then based on the specific donors, for us, it's like mostly USAID, PEPFAR, and Global Fund. And so considering all this, we jointly developed forms. And then we followed piloting, developed forms were piloted, and then we received feedback because from the relevant stakeholders. If there are any issues, then that were also incorporated while finalizing, and those forms were shared with the developer. And then training, after that, the process followed training, because all the users across the country were trained. For this, we had to develop the user manual. And this training happened in all the 7 provinces. In Nepal, we have 7 provinces. So this training was done in all the 7 provinces. And then we started data entry. And then the resources into RAM, hard disk, NS is upgraded, because in order to collect all the information and store it, the server also needs to be strengthened. So this capacity of the server, that was done. And then data was entered after addressing minor feedbacks and user details. And this was the process that was followed to create this DHIS2 tracker that we are using currently. So yeah, this finishes my part. Now I would like to request my colleague, Dr. Keshav Deuba, to present the remaining part. Thank you.
So thank you, Nidhi. So this is the interface of our developed information system. On the left side, it's a DHIS2 tracker-based platform. We have developed a web-based applications where the user can log in and record data of each client or patient enrolled in HIV care. And our web link is hivaids.gov.np. And within this DHIS2 tracker platform, we also integrated mobile health. On the right side, you can see we also developed Java-based environment independent applications to collect biometric information. In our case, it's a fingerprint, and where the service providers record the fingerprint of the client. And next slide, please. And in our DHIS2 tracker captures, we use it for registering our clients, enrolling them into the HIV program. And we also use this DHIS2 tracker platform to refer clients from HIV preventions in the field, if for outreach services or providing the community-based testing if someone is found reactive, and then we the client referred to STC sites for confirmatory HIV diagnosis. Here, the health workers can electronically transfer the client records from the field to the HIV testing sites. If someone is found HIV positive, then they are also referred to the HIV treatment centers. And we also, since the people living with HIV frequently move from one district to others, we also use this information system to transfer their records, medical history electronically from one treatment centers to another treatment centers, or from one district to another districts. Next slide, please. So this is the biometrics device we used integrated within the DHIS2 tracker, and it helps us to identify existing client. If someone provides the thumbprint and the system displays whether the client or patient is already on the system or not. If the client is already on the system, that it displays the messages. Okay, XYZ is client enrolled in XYZ services in XYZ districts. And if the health workers already record their information, then we can access the client dashboard or additional information from the biometric system to DHIS2 tracker. So we can also enroll new client into the system by using the biometric system, or also to link to add patient details into the DHIS2 tracker capture app. Next slide, please. So this slide explains about how we link the mobile health within the DHIS2 tracker. And this is the steps here for the time considerations. We link the third-party SMS gateway linked with DHIS2 for sending SMS, and we also fixed, custom scripts for type of messages and periodicity of SMS being sent to the client. Next slide, please. And I have also provided all the details how we linked biometric system within the DHIS2 tracker, and I have also provided the link here if you want to learn more about it, and you can get all the code from the GitHub. Next slide, please. So, the mobile health is it's proven to improve retention in HIV treatment among people living with HIV. So, in the system, from the system, we can push two types of text messages in the mobile of clients. One is about like appointment reminders. We send them specific messages if they want to visit to the HIV treatment sites for the viral load test or pill pickup. And we also send like general awareness messages to inform them about like they can deliver healthy babies if they consult with the health workers at the health facilities. And we send all the text messages in Nepali. Next slide, please. So, and after like developing systems, we finalize all the indicators, program indicators within our system. There are around like 11,229 indicators and program indicators. We have divided that into the 5 about like HIV prevention, testing, STI, treatment, care, and support. In treatment, we also included program indicators related to ARV, HIV treatment, also about the hepatitis C treatment or co-infected among people living with HIV. Next slide, please. And this is one example how we are monitoring the aggregated data through the dashboards at the federal level. Similarly, we can also, monitoring the data at the site level, or the health workers can also monitor both aggregated and individual level data at their site. And the provincial government also can monitor the progress of key indicators related to HIV in their province. Next slide, please. And we have used different strategies to, motivate. Next, it's just click, and so we have used different strategies and to use this information system by health workers. And we also prioritize like why the health workers with multiple responsibilities at the public health facilities, why they need to, they record the data into the GHISU tracker. So we focused on their benefits. We developed like they can easily generate monthly ART HMIS report just by clicking one button and upload it into the national system. And we also provided, both dashboard, both aggregated and individual level data so that the health facility can, plan for response or plan for viral load, sample collections, etc. And we also organized several capacity development activities. And during COVID-19 pandemic, it was not possible to organize in-person trainings and workshops. So we also developed YouTube training video series and shared with them so that they can, learn and start recording data and utilize the information system to generate report or to plan their day-to-day services. Next slide, please. And this is also one example how like federal level government are monitoring the retention and care by provinces, by different year, by different like the age group from children young to the adult one. This is just one example, and we are also monitoring several other indicators related to early warning indicators of HIV drug resistance or monitoring the line list report of viral load testings and suppression, etc. Next slide, please. So this is also like another important part is the aggregated data not always support the day-to-day, the response services at the site and province level. So we also developed several line list reports within the system where the health workers can download and analyze each client details related to, different treatment outcomes. Next slide, please. Next. So this is one example of how we are like, this is the example of monitoring Third 95 by KPs or geographies. Here we can see like we are getting this type of, disaggregated data. And here you can see like which risk groups were to reaching Third 95 gap. And it's also helping us to identify inequalities by risk groups or by genders or by geographic areas. And this type of disaggregated data we are getting in for the first time in last 15 years. So this is just one example of highlighting the importance of using disaggregated individual level routine health facility data for planning informed response. Next slide. This is the conclusion. So our information system is providing real-time data evidence from health facility level to province and federal levels, which in turn supporting monitoring progress or analyzing the effectiveness of program or interventions. It's also easily help us to identify poor performing sites or also clients so that we can, prompt investigation and implementations of programming or public health actions to improve quality of HIV services programs. And the dashboard also alerts health facilities about specific areas which require attention and support overall optimizations of client care. Next slide. And it's acknowledgement, and we have developed this information system with the guidance and leadership of the government and the funding from the Global Fund, PEPFAR, and other partners also greatly supported us to, develop infrastructures, servers, and providing trainings. And we have also involved community organizations, those who provide service at the field level. They also contributed a lot in testing and recording data, and we want to thank all of them. And thank you, and this is the end of our presentation.
Thank you very much, Niti and Keshab, for a very detailed presentation and the real-world example of the intricacies of developing a health information system. And I really like using the fingerprint for identifying individuals, which can be then confidential. There's no release of names. So we're moving now to Uganda, and we have Gerald Pandey from Uganda, who's going to talk about some of their biobehavioral surveys that they're conducting in place of Peter. Gerald, you have the floor.
Yeah, thank you. I'm going to talk about the biobehavioral survey that is light that we conducted. Peter is on. I'm presenting on behalf of Uganda. This is the presentation layout. We have I'm going to give a background about HIV in Uganda, the method that we used, overview of the IBBS Lite, what was required for us to do the task, training of data collectors, how did this impact on service delivery, challenges in the recruitment, and then the other benefits that came out of the study. Then I will slightly touch the few results and the lessons learned. Next slide. As an overview, the HIV, according to the Spectrum data of 2020, we have around 1.4 million people who are infected with the HIV, and out of that, around 1.3 are on ART. The HIV prevalence in the general population is 5.5, but this varies in the different geographical location of the country, as seen in the map. Next slide. Two approaches have been employed in Uganda for HIV viral hepatitis surveillance in Uganda. One is the integrated biological and biobehavioral surveillance. This is a community-based design, which is designed to assess the risk behaviors and prevalence of HIV and other STIs among key populations. And this is mainly done by a CDC in Uganda. We are doing it with the Crane Survey and the Makerere University School of Public Health. Then the IBBS Lite, this was developed by WHO and UNAIDS as a light version of the biobehavioral survey. It is cheap, less intense, less costly, and can be done locally. This was led by the Minister of Health. Next slide. As an overview of the IBBS Lite, this was done particularly among the PWEDs and the sex workers. Reason being that the PWEDs and sex workers have a high HIV prevalence. The prevalence of HIV among the PWEDs is around 18%, and for the sex workers is around 31%. But the beauty is that these are accessed through services, and for us, when we are providing services, they can access services through our drop-in center that is at the facilities, and most of them are government facilities and community drop-in center. But the reason why we also had to work with those two populations is because, one, we're about to establish a match center in that region. We did them in 3 districts, that is Busia, Mbale, Tororo, and we did it in 9 facilities. We did this in consultation with the Crane Survey because they were also going to do it in the same region. So they had to give us some time, and we did. And we did it during the period of May to June. Next slide. This is our study cycle. We developed the We developed the protocol in consultation with district health facilities, CSOs. Then we trained the data collectors. Those were mainly the health workers and the peers. After training them, we uploaded the refined tool into ODK. ODK is the Open Data Kit. Then we held district central meetings just to make sure that the IPs and the districts know what we are doing and the facilities. Then data collection went on and we did analysis. Next slide. Now, what was required, a previous was made to the district and facilities where we conducted the study with the following objective. One was to introduce the district authorities implementing partners and the facilities, but also to select data collectors, and we used 3 data collectors. That is 1 data coordinator, 1 data collector for sex workers, and 1 for the PWID. But also the other objective for the site visit was to identify a central training site and also to identify a pilot center. Next slide. These are pictures which were taken during the pre-visit. Next slide. These were pictures taken at the facilities. We were holding meetings with the facility to see how this will go on. Next slide. The general, yes, please. The general objective of the training was to train data collectors, those that would be involved in the data collection, but also the specific objectives for the training was to clearly understand the tool, to pilot the data collection tool, and if there are any issues that are unclear, we made them clear during the training, but also to guide the participants on the methodology and the timelines and to understand the SOPs for data collection. Next slide. This was during the training of the data collectors, and we trained the 27 data collectors. Next slide. This was during the piloting of the tool, and these are the data collectors. Next slide. During data collection, we used to have support supervision to the facility, and that we are doing support supervision during the data collection. Next slide. Support supervision to the community. Next slide. Sorry, I'm running out of time. Next slide. How did the study impact on service provision? Data collectors noted that this did not add significantly to their work that they were doing, because this was done alongside their routine activities, that is outreaches and the facility activities. And the data collection was used as a tool which would provide services to the target people, because they were screening them. So this meant that they would easily reach the targeted people. Maybe next slide. How did the clients react to the survey? Because we used their peers and the health workers who are familiar already with them. So this was not a big deal to them. They were already familiar to them and providing other services to them like HTS condoms. And when we gave the coupons contained more information about the services that was available and the contact for health workers. Next. Challenges that we faced. The flow of the money during data collection, because we are giving reimbursement to the study participants, wasn't all that smooth. So at one time, we didn't have the money. So when the data collectors tried to recruit, it was a problem, but we had to hold it until we got the money. Then some of the, after being given a coupon and coming and screened, when they are not eligible for the study and being sent away, the participants looked at the health workers or the data collectors as people were discriminating them because they expected something. Next. What were the other benefits that came out of the study? One, when we gave the coupon, they brought on board more new clients who had never been reached, and more new hotspots were identified because of the chain referral. Then the data collection exercise also increased the new positives, which led to increasing in counseling, follow-up, and referral to the preferred point of client. Then the more new negatives that were identified, that meant that they have to be provided with the preventive services like PrEP. Next. I think I've run out of time.
I'm afraid we are pushed for time. I'm afraid we are, Gerald. If you could try to wrap up now, we very much appreciate it.
Okay. I think we can just go to the next slide because these are just results. Lessons learned. This method provides a simple method of understanding the HIV prevalence and the level of services access, but using minimum resources. Then it empowers the local health service managers to conduct the study because this was done by the service providers themselves. And they also involved in refining of the data collection tool, data collection and validation of the results. It takes a short time compared to the other IBBS. Then recruiting from outreaches through chain referral was able to reach more new people whom we had not previously accessed. Utilizing local health workers and peers as data collector is possible, and this does not add much burden and workload to them. Then you can do data collection for different population at the same time because we did one for the sex workers and do it at the same time. Next slide. I think that is it. Yeah, we dismiss it. Thank you.
Thank you so much, Gerald, for a very detailed presentation. We've had some very rich discussions here about all the different aspects of monitoring, evaluation, and surveillance. BBS Lights is a very welcome addition for reduced surveys. We're going to turn to the community now, and we have two community presenters who are going to talk about community-led monitoring, which is a relatively recent addition to our monitoring tools and an essential part of hearing from the community's perspective to triangulate and validate and identify community priorities. So we're going to hear from Viet Trinh first of Lighthouse in Vietnam. Viet, please, your presentation.
Thank you, Tim. I would be very glad to go through my presentation. So if the moderator could switch to my presentation real quick. But in the meanwhile, hi everyone, I'm Viet. I use he, him, his pronouns, and I'm currently serving as the Director of Program from Lighthouse Social Enterprise here in Vietnam. So what we are is that we are a civil society organization that fights for health equity for key populations. And what I'm presenting today are 3 different models of community-led monitoring initiatives that are available in Vietnam. And some of those have already been adapted. Some of those have been already piloted. Some of them have already been scaled up in other countries, such as, different countries in Africa. So some of you may be able to see that familiarity there. But hopefully by the end of this presentation, if not, I hope that each of you would be able to find at least one model that would be most suitable, to the resources that are within your own context, that are suitable to the needs of your own populations that you're serving. And obviously, like the different sort of multilateral relationships that you have with the government, with the different implementing partners, and all the different sectors all around. So second slide, please. So as a preface, I think before I dive into this presentation, it's very important for us to understand that in order, for the community to take leadership in terms of data gathering and monitoring, we need to build capacity for them as, community health, like workers, as community health leaders, so that they would understand the different advocacy framework, they would understand research, they would understand how Q&I and like different like data monitoring frameworks would work. So that's like a very important domain of work that we should definitely invest in before we commit to community-led monitoring. Like third slide, please. Yeah. So as I dive into this model, first I would like to provide like a preface that going back to my like initial point, like by the end of this presentation, I hope that you would be able to find, like the model, that best meet the like the needs and like the resources of your own context. And like the three different models I'm presenting here are are on, like different points of the spectrum, in terms of community-led monitoring. Some of them are going to be, more based on, community resources. Some of them, like one of them is going to be like a little bit situated on the relationship between, healthcare facilities and technical organizations and the community. And the last one would require more resources, more political relationships, and more multilateral relationships, which would involve, like the Ministry of Health in your own country. So I think some of the slides are a little bit jumbled, but if the moderator is able to accommodate, please go to like the last slide. I think that would be the slide that I'm presenting now first. So it would be like the last slide in this presentation, and then I'm going to rotate back. Yeah, so like as a starter point, I guess for all communities, in different areas like in the world, we could always start, where the community would have, scant resources, but have a big need, for leadership in terms of, like data collection, in terms of, monitoring and evaluation for the like for the national HIV strategy. Then what do we do exactly? So I think that's the question that, like this initiative, which is called the Uproot Scorecard, could definitely answer for you. That it's an index scorecard that is, that was developed by Y Plus Global and was supported by UNAIDS. And luckily, like in the second round of this initiative, Lighthouse Social Enterprise, like our organization was like the implementer in Vietnam for the first time, to pilot this index. And for this index, it's very feasible. It's very easy, to implement. And like most of the people who are on, our like implementation team were, like youth themselves with who were KPs. And the process, to us felt very feasible and very youth friendly. And I think that's really like the advantage of this like index, aka like the community like monitoring initiative here. And its purpose is to measure the meaningful participation and leadership of adolescents and young people in national HIV strategy. As you could see on the left, you could see like the different scores and the scoring key as well. So what I would want you to pay attention here is like the different scoring key. So as you could see that like the different scores in like the 5 domains fall in different sort of scoring key, I guess, colors. Like the green would be like the scores that correspond with the green would signify that your country is doing quite well in that area, and perhaps we should draw attention to like other sections. So if we could go back to the third slide, please. So what I'm presenting next is like another model of community-led monitoring that will require like a little bit more resources, and absolutely, it will be very important for us. Previous slide, please, the third slide. It's called a KP-friendly model. So for the KP-friendly model, it situates on this very important triad between, healthcare facilities, the, like the technical like organizations and the community itself. And the reason why that like this triad is very crucial, for this whole ecosystem to run is the fact that there is like feedback in each of these entities, and even between healthcare facilities with the communities as well. So can I go to the next one? And as you can see, like for this project, there are a lot of activities that we could do, for the monitoring. There are a lot of pre and post assessment, for us to gauge whether, where these healthcare facilities are in terms of their QI and like their KP friendliness. And then there's going to be like these consensus meetings between, like the communities, like the technical organizations and the healthcare facilities who are aiming to improve their quality. And then there's going to be redecoration, so that the environment of that clinic or that hospital, could be friendlier, for the, for, KPs. For example, like displaying like rainbow flags or signs that are going to be less destigmatizing. And then there's always going to be like those endline, activities as well. Next slide. And then these are like the different figures that we think really demonstrate the good work for this model. Like a lot of the sites. So we got to, accomplish, like the sensitization and destigmatization for over 360 healthcare workers and non-medical health staff, so that, like the stigma and discrimination for KPs could decrease. And 6 different CBOs got, capacity like citated, so that they could provide feedback and collect the community feedback, to these facilities for continuous improvement. Next slide, please. And next slide, please. And this last model that I'm presenting to you is called the CAP, which stands for Consumer Advisory Boards. That is like a model that was previously like developed by like in the U.S. And what these like consumer advisory boards do is that they would participate in different QI like initiatives, such as conducting community scorecards, to evaluate the health service quality, from the client perspective, and they themselves would be the different peer educators, the different community health workers who are going to be engaging in discussions about, the quality of care, and inform these clients about the available services. Next slide, please. And one of the client feedback activity that we did, for the CAP was, for them to kind of like distribute these forms, to the clients themselves, so that they could better understand what the clients are looking for and are, are the agents of evaluating the services that they just experienced. And from this, like these forms, we can like pull the data, and go back to these different like healthcare facilities and, the Ministry of Health and like themselves in these like different congregation meetings and discuss how we could, put these feedback, into real changes and actions. Next slide, please. And these are some of the very outstanding results from, like the CAP. As you can see, I can just like mention like a few here. Increased client confidentiality is super important, and especially when you're working with KPs who are, like MSM, female sex workers, or transgender women. Confidentiality is the #1 key factor, for their access, to the services, and also reduce, like clinic waiting time is super crucial, and we got that from 60 minutes to 60 minutes. Next, please. Yeah, so like the above figures really like wrapped up like the success for the CAP model, as well as my presentation, and I look forward to like the different comments that you would have, any questions that you have, for the 3 different models that I presented, I would gladly welcome them. Thank you for your attention. Thank you.
Thanks very much, Viet, showing the great contribution of community-led monitoring to our overall understanding of the epidemic and patient management and feedback on services. We are running over, but we have one more presentation from Shanaz of TAIS Plus in Ukraine. We apologize, Shanaz, but the floor is now yours. I think we have to
Спасибо,
get back
Тим.
in
Здравствуйте
the
всем.
slide.
Меня зовут Шахназ, я представляю ТАИС Плюс. Наша организация находится в Кыргызстане. ТАИС Плюс – это общинная организация, которая создана и управляется самими секс-работниками. Нашей миссией является усиление сообщества секс-работников с тем, чтобы достичь более достойных условий жизни и труда для секс-работников. Как инициативная группа мы начали работать в 1997 году, официально зарегистрировались в 2000 году в марте. У нас достаточно большой опыт проведения мониторинга силами сообщества. Можно переключить через слайд, вы опаздываете немного. Значит, мы проводим мониторинг силами сообщества в период с 2016 года, и он продолжается по сей день. Где мы проводим? Мы проводим его во всех областях нашей страны, где существуют либо работают программы профилактики ВИЧ-секс-работниками. Основная поддержка до прошлого года у нас была ПРООН. Это проекты глобального фонда по компонентам усиления систем сообщества, СВАН по проекту Роберта Кара и НСВП – это проект инициативы глобального фонда сообщества «Права и гендер». Какой же наш основной подход? Основной подход мониторинга силами сообщества для нас является СВИД. Это руководство по реализации комплексных программ по профилактике ВИЧ, инфекций, передающихся половым путем, вместе с секс-работниками. Это, можно сказать, наша такая конституция, на которую мы опираемся в ходе всей своей работы, не только во время мониторинга силами сообщества. Какая у нас аудитория? Значит, основную часть мероприятий с секс-работниками реализуют неправительственные организации, поэтому в первую очередь мониторинг мы проводим с теми неправительственными организациями, которые работают с секс-работниками. С 2020 года также представители службы СПИД и медицинские учреждения, которые предоставляют ИПП-сервис, сервис по предоставлению АРВ-терапии, консультированию, тестированию, также были включены в программу нашего мониторинга. Что такое для нас мониторинг силами сообщества? Это такой процесс, когда сами сообщества собирают информацию о том, каким образом предоставляются услуги, об условиях, которые влияют на качество и доступность этих услуг, о тех правовых барьерах, с которыми сталкиваются само сообщество секс-работников и организаций, которые работают с ним, и многое другое. Далее мы используем эту информацию для того, чтобы улучшать качество услуг, добиваться улучшения правовой среды и повлиять на ход выполнения проектов. В конечном итоге все полученные нами данные во время мониторинга силами сообществами должны становиться обязательным компонентом национальной программы мониторинга и оценки. Что для нас СВИД? Я уже говорила, что это наша конституция, это та наша основа, через которую мы смотрим на все наши программы, которые выполняются с секс-работниками. И любой мониторинг силами сообщества должен быть основан на каком-то идеале или эталоне. Для нас этот идеал, этот эталон, это СВИД. Мы постоянно стремимся к тому, чтобы улучшиться, сравнивая то, что у нас есть сегодня, и то, что мы хотим видеть, какую ситуацию хотим мы видеть завтра. Ну, это, как я уже говорила, СВИД – это вот наши очки, через которые мы смотрим. Какие инструменты МСС у нас есть? Перед каждым визитом обязательно мы готовим план, вернее, сперва мы готовим план мониторинга на год. Перед каждым визитом обязательно готовим техническое задание для той команды, которая выезжает на мониторинг силами сообщества. Также перед тем, как выехать, обязательно для команды мониторщиков проводится обучение, подготавливаются опросники для сотрудников организаций, для дружественных врачей, адвокатов или госучреждений в зависимости от того, с кем мы будем встречаться на данном мониторинге. Темы этих опросников могут быть разными в зависимости от цели. Ну, например, там это может быть ДКТ или ПП-сервис, либо правовая поддержка или участие самого сообщества в жизни и деятельности НПО. Обязательно у нас проходят встречи с секс-работниками. За весь период с 16 по 20 год мы разработали набор опросников для проведения интервью и фокус-групп, а также планы бесед с секс-работниками. В какой форме мы проводим мониторинг? Ну, это визиты в организации, которые предоставляют услуги секс-работникам. Это, как я уже говорила, могут быть как неправительственные организации, так и частные клиники, государственные учреждения. Обязательно проходят встречи с секс-работниками. Есть опросники, которые заполняют сами секс-работники. Это у нас довольно-таки новые опросники мы разработали для рутинного мониторинга силами сообщества. Проводим сбор запросов о проблемах, с которыми столкнулись секс-работники, и решение этих проблем. В каждую нашу поездку, на каждый визит мониторинга мы обязательно оказываем какую-то техническую помощь по запросу либо самих секс-работников, либо по запросу организации, в которую мы едем. На данный момент перед нами стоит задача сделать мониторинг силами сообщества более регулярным процессом и с более широким участием сообщества. Какой же у нас состав команды? В идеале команда должна состоять из представителей сообщества. Количество выезжающей команды не должно быть очень большим, это 2-3 человека. Но есть некоторые темы, например, такие как правовая помощь, где нужен специальный человек с юридическим образованием. В этом случае мы можем пригласить юриста поехать вместе с нами на подобный мониторинг. Значит, партнерский подход при мониторинге силами сообщества. Это следующий слайд. Особенность нашего мониторинга в том, что мы не едем выполнять контроль. Мы приходим в организацию как к нашему партнеру, признавая ту ценность работы, которая уже налажена и отстроена в данной организации. Мы стараемся понять особенности работы в другом городе, потому что от региона в регион условия работы, то, как разговаривать с людьми, может отличаться. Если в крупных городах есть где-то более откровенные разговоры, то в малых городах либо селах нужно где-то какие-то более подбирать более тщательно то выражение, которое ты хочешь сказать. Мы понимаем, что после нашего визита сразу все не изменится, и эти изменения будут постепенными. Вместе с организацией, куда мы приезжаем, либо сообществом, мы ищем возможности для улучшения качества услуг и ситуации в целом, особенно в области прав человека. На практике мы делимся собственными примерами работы, например, в таком направлении, как усиление сообщества. Делимся результатами совместной работы. Это могут быть отчеты об исследованиях или итоги подготовки страновой заявки. Вместе отрабатываем практические навыки в формате мини-тренингов или в поле, если мы встречаемся с секс-работниками. Ну и, естественно, у нас есть отчетность об итогах мониторинга силами сообщества. Сначала отчет о визите с выводами и рекомендациями. После того, как мы напишем, мы согласовываем с организацией, в которую был выполнен визит. После этого отчет с результатами мониторинга рассылаются основным донорам, которые финансируют программы в стране, представляются на заседаниях СКК и направляются в госучреждения. Также результаты мониторинга представляются на подходящих встречах и семинарах, но это могут быть встречи там, с субполучателями грантов Глобального фонда, либо какие-то другие тематические встречи, которые посвящены определенной проблеме. И эти же данные мониторинга сообщества используются при разработке национальных документов. Например, последняя последнее использование было для разработки национальной программы по ВИЧ и для страновой заявки в Глобальный фонд. Какую же пользу мониторинг силами сообщества принес сообществу секс-работников за все время в его внедрении? Во многих организациях изменились подходы в работе проведения тестового консультирования и тестирования. И если раньше оно проводилось там быстро-быстро за 5 минут, то сейчас его проводят уже более глубоко и с партнерским подходом, а не относятся как к клиентам программы. Мы учились друг у друга и перенимали опыт, который есть у другой организации. Например, как получить государственное финансирование или как проводить диагностику и лечение инфекций, передавшихся половым путем, где секс-работники могут вносить часть оплаты самостоятельно. Результаты мониторинга помогают увидеть приоритеты и включать их, как я уже говорила, в страновые заявки. Мы разработали новые инструменты для рутинного мониторинга. Сейчас они внедряются уже во всех областях нашей страны. Секс-работники и сотрудники, они же являются сотрудниками ВИЧ-сервисных организаций, они становятся в позиции экспертов от сообщества, проводят самостоятельно интервью. За эти годы они приобрели очень много навыков мониторинга и проведения исследований. ВИЧ-сервисные НПО за годы проведения мониторинга постепенно начали менять свои подходы работы и свое видение. Благодаря этому наши совместные адвокационные усилия дают больше результатов. Но, конечно же, у нас есть проблемы, никто их не избегает. Это то, что обучение мониторинга и приобретение
We have
практических
to wrap
навыков.
up soon, Shanaz, I'm afraid.
Это последний слайд. Обучение, приобретение практических навыков – это длительный процесс и требует больших ресурсов. За последние годы у нас обучение прошло около 40 человек из сообщества. Но люди меняются, и постоянно надо обучать новых людей. На это, естественно, нужны ресурсы. Секс-работники являются экспертами в мониторинге, в то же время остаются сотрудниками неправительственных организаций, и это иногда влияет на их позицию. Люди не говорят то, что может навредить организации на своем месте. Ну и, как я уже говорила, для того, чтобы мониторинг силами сообщества расширялся, требуются дополнительные ресурсы. Ну, наверное, на этом я закончу. Спасибо.
Thank you very much, Shanaz, for a very detailed and interesting presentation on the benefits and how the details of how you actually conduct CLM. I'm very sorry we've run over time, everybody, but it's been a really rich presentations showing many different aspects of surveillance and monitoring. We've heard about the use of data at the global level, the use of collection of data in health information systems for patient management, client management, about the biobehavioral surveys and how we can collect more information on knowledge, attitudes, and behaviors. And lastly, about the community-led monitoring, which is really getting into the detail of what are the issues of concern to the key population themselves. So I'd like to thank all of our presenters. We've had a lot of interest, but we have to call it to a close. I'll draw your attention in the chat. There is another key population webinar from PEPFAR for the EPIC project. That's going to be happening 8 to 9 a.m. Eastern time, which you can see the link there if you're interested in joining that one. But we'll call this webinar from the Community of Practice for Key Populations to a close here, and thank everyone for participating. Good evening, good day, bye.